to reduce the clutter on your table, you need a direction. So something like PrepLadder gives us that direction. You have some 40 hours or 50 hours of gynecology.
I have given all the content of pharmacology.
I've contributed the entire content for internal medicine.
I have created the content for PSM.
You can trust the questions and explanations to be genuine.
Detailed explanations will help you solve the different variations of the same question.
Textbook references will help you authenticate an answer.
I have created this content after close inspection of the previous year questions.
I have put in my 14 years of experience into creating these questions.
Includes the latest exam questions, questions on the recent updates, as well as image-based questions.
All questions are according to recent exam trends and difficulty level.
So the software would be exactly like the real exam.
All your queries come directly to me.
So if you have any kind of doubt, you can ask me directly.
I'll be solving all your microbiology related queries.
You can ask anything about the subject, doesn't have to be only about a question.
I'm always available for you whenever you need help.
You can have a counseling session with me.
So we've put in features to make sure you keep studying. The PrepLadder app will never let you fall behind.
Solving obs and gynae questions will be easy for you after this.
You would not have to worry about anatomy at all.
You will be able to solve most of the questions in PSM.
Most pathology questions in the exams are going to be derivatives or the repeats from these questions.
1 lakh competitors.
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 It's good to see that everyone in the team is giving their best.
This is the best team of faculties that could have been put together.
This is the biggest innovation in medical education.
We are obsessed with making sure that you get the best value out of every minute spent on the PrepLadder app.
Really happy to be a part of Team PrepLadder.
You know, if there was something like PrepLadder when I was preparing, I'm sure that I would have prepared much better because I would have known what to read.
So we are going to start kidney and ureter. And first of all, renal stones. Now see how these renal stones are formed. For formation of any kind of stone, there are two things which are mandatory. One is supersaturation and second is crystallization. Now what is the meaning of this statement? It's very simple. Imagine that the stone is calcium oxalate. So there should be supersaturation of calcium as well as supersaturation of oxalate in the urine. It means patient is having what? Hypercalciuria or hyperoxaluria. Because of this, what happens? There is precipitation. And after precipitation, what will happen? There is formation of microcrystals. These microcrystals will join together and form macrocrystal. So this is crystallization. And supersaturation means when it is saturated, after that there is tendency of formation of crystals. So supersaturation and crystallization, these are two mandatory factors for stone formation. That's why in management of stone, if we are going to dilute the urine, what happens? There is no saturation. And if there is no saturation, there is no supersaturation and there is no stone formation. That's why this is the basic principle used in the treatment of renal stone. What? We have to dilute the urine. And that's why we ask the patient to take plenty of fluids, plenty of water, so that urine is diluted and there is no precipitation. So this is first principle. Second principle, no need to remember risk factors in majority of cases. Why? Just look at the composition of stone. If the composition is calcium oxalate, calcium plus oxalate, it means there is increased concentration of calcium in the blood known as hypercalcemia, increased concentration of calcium in the urine known as hypercalciuria, an increased concentration of oxalate in the urine, what? Hyperoxaluria. Similarly, uric acid stones are seen in patients of gout, Lesch-Nyhan syndrome, cystine stone seen in the cases of cystinuria, xanthine stone seen in the cases of xanthinuria. So these are the basic concepts. Now we are going to discuss in detail. One question is asked, what are Renal plaques? Renal plaques. These renal plaques are nothing but the soft tissue calcification found in deep renal medulla. And these are acting as nucleating agent for renal stones. So Renal plaques act as a nucleating agent for renal stone, and these are soft tissue calcifications found in deep renal medulla. So we are going to discuss in detail the renal stones. First, types of renal stones. Calcium oxalate. This is most common type of renal stone. Now you can see what is the composition. Calcium plus oxalate. So the risk factors are hypercalcemia, hypercalciuria, hyperoxaluria. And there is a simple principle. Most of the stones which contains calcium, those stones are usually radio opaque and hard. So you can see this calcium oxalate stone is radio opaque. Next is uric acid stone. Very important point. It's the most common type of radiolucent renal stone, and it is seen in which patients? Risk factors are gout, Lesch-Nyhan syndrome, and myeloproliferative disorders. What happens in myeloproliferative disorders? There is increased breakdown of cells, and because of that there is conversion of hypoxanthine into xanthine, and this xanthine is converted into uric acid when chemotherapy is being given. Because of that there is breakdown of cells. So what is the pathway? In this case there is conversion of hypoxanthine into xanthine, and this xanthine is converted into uric acid. Now there is another simple principle in the management of stone. If stone is acidic, go for alkalinization of urine, and if stone is alkaline or basic, go for acidification of urine. Why? Because acid combines with alkali and there is formation of salt. Salt is soluble. So if uric acid stone is there, we can easily go for alkalinization of urine. There is formation of soluble salt, and that soluble salt will be excreted in the urine. One. Second principle I told you, at any cost you have to dilute the urine. And third, here you have to prevent increased production of uric acid. So you have to take low purine diet. So what are the management options here? First, plenty of fluids. Low purine diet. Acetazolamide is used for alkalinization of urine. Acetazolamide for alkalinization of urine. And fourth, if patient is not responding, in that case, can you see both of these steps are blocked by one drug. What's the name? Allopurinol. Allopurinol is going to block the conversion of hypoxanthine into xanthine and xanthine into uric acid. So here, drug of choice is allopurinol. So this is how we manage the patients of uric acid. Third, struite. What are the other names of struite? It is also known as Staghorn calculi. It is also known as triple phosphate stone. What do you mean by triple phosphate stone? It is calcium, magnesium, ammonium, phosphate. Calcium, magnesium, ammonium phosphate stone. All of you know that this is more common in females. Why it is more common in females? Because females are having short urethra. How much? 4 centimeter in length. Because of this short urethra, there is increased risk of UTI. Which organism is responsible for UTI? Here, most commonly, the organism is protease. And this protease produces what? Enzyme, urease. And you can see this urease converts urea into ammonia. Urease. It converts urea into ammonia. And what will happen? Can you see? This ammonia is precipitated here. So this leads to formation of calcium, magnesium, ammonium phosphate. Now what is the biggest problem in this case? Yes, the stones are very large. They fill the whole pelvic calyceal system and they causes silent destruction of stone. So see, stones are very large. Now have a look of anatomy of kidney first. This is kidney. In this kidney, these are the minor calyces. And there are 3 to 5 minor calyces. These are going to join and form major calyx. This is pelvis, this is ureter, and this is junction known as PUJ. These are minor calyces. So 3 to 5 minor calyces going to join, form major calyx. After that there is pelvis, then there is pelviureteric junction and there is ureter. Now see, this stone is very large. Can you see? This is a very large stone and it is going to fill this whole pelvic calyceal system. If I am going to take out the stone, can you see the shape? The shape of this stone is something like this. And it looks like what? The stag horn. Horn of stag. Stag horn. Why? Because there is branching in the stone. So because of branching in the stone, it looks like stag horn. So there is branching. It looks like stag horn, and that's why it is known as Staghorn calculi. These stones are very large and it causes silent destruction of kidney. So how we are going to remove these stones? Be careful. Stones are so large that single technique is not effective in the removal of stone. That's why we go for sandwich technique. What is this sandwich technique used? Here we are using PCNL plus ESWL. PCNL means percutaneous nephrolithotomy and ESWL means extracorporeal shockwave lithotripsy. We will discuss in detail. Percutaneous nephrolithotomy plus extracorporeal shockwave lithotripsy. So this is the technique used for removal of these bigger stone or Staghorn calculi. Now second problem. Since female urethra is 4 cm, she is again prone to get the infection by protease. And if a female is having recurrent stone formation, especially because of protease infection, and the type is Staghorn calculi, what we can do? We can give an inhibitor of urease. So for recurrent stone formation, to prevent recurrent stone formation, irreversible inhibitor of urease is given. And what is that irreversible inhibitor of urease which is given? It is acetoxy hydroxamic acid. So this is acetoxy hydroxamic acid. which is irreversible inhibitor of urease given for the patients who have recurrent stone formation, especially this triple phosphate or Staghorn calculi. Next, cystine stone. Cystine stone is seen in cystinuria. And be careful, there is no calcium. Then also these stones are radio opaque. Why these stones are radio opaque? Because of this double sulfur bond. These stones are very hard, not easily broken by ESWL. What kind of crystal is there? Can you see? This kind of crystal is there. This is benzene shaped. There is benzene shaped crystal, also known as hexagonal crystal. Now you can see that this cystinuria is a metabolic disorder. If you can give some agent which can bind with this cystine in the urine by forming some complexing agent, by giving some complexing agent that will be excreted in urine. So what are those agents which are given? There are two drugs which are given. One is D-penicillamine. This is frequently asked in exam. D-penicillamine, it's a complexing agent. And second is alpha MPG, full form alpha mercaptopropionil glycine. So alpha mercaptopropionil glycine, these two agents are used. What is the problem with D-penicillamine? The patient compliance is not that good because of side effects. That's why alpha MPG is preferred over D-penicillamine. For cystine stones, alpha MPG is preferred over D-penicillamine. Fifth, xanthine stone. So obviously, this xanthine stone is seen in xanthinuria. Now see what is this? Can you see here there is conversion of hypoxanthine into xanthine, and there is excretion of xanthine, that is known as xanthinuria. It means one principle is simple. Here also we can use one drug which can block this step. And what drug can be used here? We can easily use allopurinol. This is a simple question. Xanthine stones are radiolucent, and just by looking at the stone you can identify that it is xanthine stone. How? Because of color. Why? What's the color? It's the brick red in color. And there is second very important point. It shows lamination on cross section. These are two important points which are asked in exam. It's brick red in color and it shows lamination on cross section. And for treatment what we can use? Allopurinol, because it blocks conversion of hypoxanthine into xanthine. After that, next stone, triamterene. What is this triamterene? This is potassium sparing diuretic. This question is asked in medicine, in pharma as well as in surgery. Excessive use of potassium sparing diuretic leads to formation of radiolucent stone. Similarly, there is another drug which leads to increased risk of stone formation, and that's indinavir. What is this indinavir? This is protease inhibitor used in HIV, and again this can lead to formation of radiolucent stone. Next stone is silicate stone. Now see how these silicate stones are formed. Excessive consumption of antacids containing silica. excessive consumption of antacids containing silica. So these leads to formation of silicate stones. Now out of these stones, what are the stones which are radiolucent? There is a mnemonic. Mnemonic is TICSU. TICSU is radiolucent. So what is full form of TICSU? Here, trimterene, indinavir, xanthine, and uric acid. So trimterene, indinavir, xanthine, and uric acid. Clear? After that, questions are asked, in which cases stones are acidic? See, CCU is acidic. What is the full form? Calcium oxalate. Second, cystine. And third, uric acid. So these are acidic stones. Questions are asked that these stones are more common in males or females. We are going to discuss in detail. Now we are going to discuss in detail the renal stones. Renal stones are more common in males but infectious renal stones are more common in females. So renal stones are more common in males, infectious renal stones more common in females. Now we are going to discuss very important topic, and that is genitourinary tuberculosis. So have a look. Genitourinary tuberculosis. First question, what is the most common organism responsible? The most common organism responsible obviously is Mycobacterium tuberculosis. Now see, initially which organ is involved primarily in Mycobacterium tuberculosis? It is the lungs. Lungs are primarily involved. Genitourinary tract is secondarily involved. This genitourinary tuberculosis is more common in males. In which particular age group it is seen? It is seen in 20 to 40 years of age, means second to fourth decade. What is the most common route of spread? Here, most common route of spread is hematogenous. Which organ is involved first? Primary organ is lungs. So from lungs, there is hematogenous spread and there is involvement of genitourinary tract. Directly from lungs, two organs are involved which are primarily involved, that is kidney and prostate. Rest of the organs are secondarily involved because of ascent of infection or descent of infection. What is the meaning of this statement? Have a look. See the meaning. Now can you see? This is kidney, this is ureter, this is bladder, this is prostate, this is urethra, and this is what? Ejaculatory duct or vas deferens. This is ureter. Now from lungs, kidney and prostate are primarily involved by hematogenous spread. So from hematogenous spread, kidney and prostate is primarily involved. Clear? After that, rest of the organs are involved by either ascent of infection or descent of infection. What do you mean by ascent? Can you see? The infection is going to ascend up a bit and it is going to involve what? Vas deferens. So this is ascent of infection. Now can you see? From kidney, this infection is reaching ureter and after that it is reaching bladder. This is known as what? Descent of infection. So there is ascent of infection and there is descent of infection. Now see how these organs are involved. We are going to discuss in detail. First about kidney. From hematogenous spread, the bacteria is lodged into periglomerular capillaries. Bacteria is lodged into periglomerular capillaries. What is the good thing? Most of us are having good immunity. That's why the infection is cleared. Or this infection is still there in the dormant state. Whenever our immunity goes down, if immunity goes down, there is activation of the bacteria. And if there is activation of this bacteria, there is formation of what? Cortical granuloma. After this cortical granuloma, there is formation of what? Tubercular abscess. And whenever there is formation of tubercular abscess, it ruptures into pelvic-calycial system. And after that, it is coming out, the pus is coming out via urine. And patient is having increased frequency. When you are sending this for urine RM, you are going to see pus cells. You are sending it with for culture sensitivity. There is no growth within 48 hours. Means on culture sensitivity, it's sterile. So it leads to what? Sterile pyuria. I'm repeating. When pus is coming in the urine, patient is having increased frequency. And this is the most common, earliest symptom. Most common, earliest symptom of genitourinary tuberculosis. When the urine sample is sent for urine RM, there is pus cells but no growth on culture sensitivity within 48 hours. That's why it's known as sterile pyuria. Now see how it's going to occur. Very simple. This is kidney. Initially there is formation of cortical granuloma. After that there is formation of tubercular abscess which is going to rupture into pelvic-calycial system. And this pus is coming into urine, going out. Patient is having increased frequency. On RM, there is urine RM, there is pus cells. On culture sensitivity, no growth. There is sterile pyuria, which is a characteristic feature of tuberculosis. Be careful, it is just the beginning. Now, various sequence of events are going to occur in kidney, ureter, bladder, prostate, vas deferens. So what are those events? One by one we are going to discuss. Have a look. In kidney and ureter, what happens? There is calycial stenosis or there is stenosis at PUJ. Because of this stenosis or obstruction, there is hydronephrosis or pyonephrosis. Be careful, it can also lead to what? Perinephric abscess. All of you must be knowing that in tuberculosis there is caseous necrosis and kidney is filled with cheesy material. So there is caseous necrosis, and because of this, kidney filled with cheesy material. This question is asked in pathology. When the kidney is filled with cheesy material, this is known as what? This is known as putty kidney. After that, what will happen? There is calcification. And see, calcified kidney. This question is also asked. Calcified kidney is known as, this is known as cement kidney. Calcified kidney is known as cement kidney. And after that what? It becomes non-functioning. So this non-functioning calcified kidney, yes, this is known as autonephrectomy. So there is non-functioning calcified kidney which is known as autonephrectomy. So these are sequence of events. Be careful. Autonephrectomy is seen in renal tuberculosis, but autosplenectomy is seen in sickle cell anemia. So these are the sequence of events in kidney and ureter. Now see what happens in bladder. Very easy. This is kidney, this is ureter, and this is bladder. What happens? Whenever infection from ureter is going into bladder, initially there is pallor around ureteric orifice. So question is asked, what is the initial sign visualized on cystoscopy? Whenever we are going to perform cystoscopy, what's the initial sign visualized in tuberculosis? And that is very careful. That is pallor around ureteric orifice. Be careful, you people are going to do the mistake. In the question, you will also find the option golf hole ureteric orifice. That is seen in advanced case when there is contracted bladder. Earliest sign is pallor around ureteric orifice. What is the next stage? After that, can you see? This is bladder. In the bladder, there is chronic inflammation going on and there is formation of what? Tubercles. Because of this tubercles, what is happening? There is chronic inflammation. After chronic inflammation, there is fibrosis. And what happens after fibrosis? After fibrosis, there is contraction. So if there is contraction, can you see how this bladder will convert? Now the bladder will become something like this. So bladder is going to become something like this. What? Small contracted bladder. Clear? So bladder is small and contracted. So it's something like this. Can you see the capacity of bladder? It is highly reduced. So small contracted bladder with highly reduced capacity. What is the shape of this bladder? It looks like thimble. It looks like thimble, and that's why it's known as thimble bladder. So small contracted bladder, also known as thimble bladder. Now see how ureter is going to enter into bladder like this. If the bladder is going to contract, what will happen? Can you see? The ureteric orifice will be up, and what? At the site of ureteric orifice, there is increase in size. So what? Can you see? The ureter will be up, and in this case, can you see? The appearance will be something like this. And at the site of ureteric orifice, this kind of hole is there. This kind of presentation is there. Be careful. This is known as golf hole ureteric orifice. It's not golf hole ureter. It is golf hole ureteric orifice. So there is small contracted bladder known as thimble bladder. When it is going to contract, the ureteric orifice will be enlarged relatively, known as golf hole ureteric orifice. Now what's the change in prostate? Prostate is calcified. If the prostate is calcified, it becomes hard and nodular. It becomes hard and nodular. Clear? Okay. Now see, you have seen this diagram. In which kidney and prostate was involved primarily, ureter, bladder, and this vas deferens was involved secondarily. You are going to see that there is one organ which is missing. Which organ is missing here? Yes, testes. So what? Testis is spared. In genitourinary tuberculosis, testis is spared. Now what are the changes in the vas deferens? Can you see the changes in the vas deferens? These are the changes in the vas deferens. Have a look. This kind of appearance is there in the vas deferens. Can you see? This is scrotum. Now what? There is stricture, dilatation, stricture, dilatation, stricture, dilatation. And this appearance is known as beaded appearance. So there is beaded appearance of vas deferens. Simultaneously, at the areas of dilatation, there is pus collection. So these are the areas of pus collection. After some time, this pus is going to rupture and there are multiple discharging sinuses via scrotum. So this is asked in exam. Beaded appearance of vas deferens with multiple discharging sinuses. With multiple discharging sinuses via scrotum. It is characteristic feature of tuberculosis. So these are the presentations. Right? Now we are going to perform the investigations. We are starting from urine RM and urine CS. Have a look on investigations. Urine RM, what is there? Pus cells. And urine CS, there is no growth within 48 hours. And if there is no growth within 48 hours, this is known as what? Sterile pyuria. If I'm going to perform IVP, what are the findings? Earliest sign of renal tuberculosis, earliest on IVP is moth-eaten calyx. This is frequently asked in exam. Earliest sign of renal tuberculosis is moth-eaten calyx seen on IVP. So question is asked, investigation of choice for diagnosis of earliest changes of renal tuberculosis. Earliest changes of renal tuberculosis is IVP. So this is investigation of choice for diagnosis of earliest changes of renal tuberculosis. And what are those changes? One is moth-eaten calyx. Other changes are, there is calyctasis, there is space occupying lesions, there is hydronephrosis. So all these changes you can see on IVP. But be careful, investigation of choice for diagnosis in renal tuberculosis is CCT. Investigation of choice for diagnosis of renal tuberculosis is CCT. Two questions. Investigation of choice for diagnosis of early changes of renal tuberculosis, IVP, and investigation of choice for diagnosis of renal tuberculosis, CCT. If I'm going to perform RGP, that is retrograde pyelogram, we are going to find what? Pipe stem ureter. What is this pipe stem ureter? It's the medial deviation of ureter. So this is how we are going to confirm the diagnosis of renal tuberculosis. When the diagnosis is done, we have to start the treatment, and the treatment is ATT. Apart from ATT, what else should be started? We are going to manage. So management of complications. So what are those complications which we are going to manage? First, for ureteric strictures, we have to perform dilatation. For small contracted bladder or thimble bladder, we have to increase the capacity of bladder with the help of small bowel mucosa, that is known as augmentation intero. Augmentation interocystoplasty. So we have to perform augmentation interocystoplasty. Third, if the kidney is non-functioning, there is non-functioning kidney, in that case we have to perform what? Nephrectomy. So for non-functioning kidney we have to perform nephrectomy. Fourth situation, sometimes the lower part of ureter is involved and there is a stricture which cannot be dilated. So for non-dilatable stricture, of lower third of ureter, non-dilatable stricture of lower third of ureter, in this case Boary's operation is performed. Boary's operation performed. What is this Boary's operation? Have a look. Very simple. This is kidney, this is ureter, and this is bladder. Now what? This part of ureter is having non-dilatable stricture. What we are going to do? We are going to excise this part of ureter. This part of ureter is removed. After that, we are going to raise a flap from the bladder. And after raising the flap from bladder, we are going to tubularize this flap, and after that we are going to suture this defect. So we are going to suture this defect. So after suturing this defect, what is the final diagram? The final diagram will be something like this. Have a look. It's like this, and this defect is sutured. So this is known as Boary's flap, and this operation is known as Boary's operation. So this is how we are going to manage the patients of genitourinary tuberculosis. Now we are going to discuss very important topic, and that is RCC. We will be discussing RCC under two different topics. One, pathological aspect, and second is the surgical aspect. So first have a look of pathological aspect. What are the types of RCC? The most common variant is known as clear cell. Clear cell variant. This is most common type of RCC. It arises from PCT, proximal convoluted tubule. Here it is written clear cell, but be careful, cell is not clear. In these cases, cell contains glycogen and lipids. This glycogen and lipids is washed away during staining and fixation, and that's why cell appears clear. So be careful, cell is not clear, cell appears clear. Question is asked, what is the most common gene mutated in this case? The name of gene, VHL gene. Question is asked, this VHL gene is located on which chromosome number? 3. And which process is going to occur on this chromosome number 3? There are two processes. One is deletion, and there is second process, translocation. So either there is deletion of this gene or there is translocation on chromosome number 3. You must be knowing that for translocation, how many chromosomes are required? 2. So that's why the combination is 36, 38 and 311. So in translocation, 36, 38 and 311, these are the chromosomes which are involved. So this is clear cell variant, which is most common type of RCC. Second is papillary variant. So first question, it's written, it is having papillary projection. So this tumor is having papillary projection. Second question, it is the most common type of RCC. Most common type of RCC seen in patients of cystic disease requiring hemodialysis. So be careful. It is most common type of RCC seen in patients of cystic disease requiring hemodialysis. What is the name of gene which is mutated? Here, the name of gene is MET gene, and it is located on chromosome number 7. Which process is going to occur on chromosome number 7? There is trisomy. In trisomy, not only chromosome 7 is involved, there is involvement of 7, 16 and 17. So in trisomy, there is involvement of 7, 16 and 17. This question is frequently asked. Papillary variant arises from PCT or DCT. Initially, it was assumed that it was arising from DCT, but nowadays the latest theory says that it arises from PCT. This is a potential question. It arises from PCT. There is another special feature that this tumor is hemorrhagic and cystic. So it is a tumor is associated with hemorrhage, so it's hemorrhagic and cystic. And you must be knowing that it is associated with dystrophic calcification. And what is that dystrophic calcification? That dystrophic calcification is known as what? Psammoma bodies. So this question is frequently asked. What are the conditions in which psammoma bodies are seen? And the mnemonic is PSM. What is the full form? P. Papillary carcinoma thyroid and papillary variant of RCC. S. Serous cystadenoma ovary. Serous cystadenoma ovary. And what is M? M is meningioma. This question is frequently asked. So semoma bodies are seen in papillary carcinoma thyroid, papillary variant of RCC, serous cystadenoma ovary and meningioma. Third is chromophobe. This is very important and frequently asked in exam. First question, this chromophobe variant is having best prognosis. It arises from intercalated cells of collecting duct. So it arises from intercalated cells of collecting duct. It is having plant cell appearance. So why it is having plant cell appearance? Can you see what kind of appearance is there? Have a look. There is relatively clear cytoplasm and the cytoplasm is eosinophilic. Relatively clear cytoplasm which is eosinophilic. After that, have a look of nucleus. There is a nucleus with fine chromatin. So there is fine chromatin. After that, there is thickened membrane. Thickened membrane. And what else? There is perinuclear halo. Halo means empty appearances. So what? There is thickened membrane. And there is perinuclear halo. So that's why it is having plant cell appearance. After that, questions are asked. What are the chromosomes which are lost in this case? 1, 2, 6, 10, 13, 17, 21 and Y. These are the chromosomes which are lost. In one exam, these two were mentioned in the option 1 and Y. So these are the chromosomes which are lost. How many chromosomes? Multiple. So it is characterized by multiple chromosome losses. And because of this multiple chromosome losses, there is extreme hypodiploidy. So there is multiple chromosome losses leading to extreme hypodiploidy. All these are the questions which are frequently asked about chromophobe. Fourth is Bellini duct carcinoma. Bellini duct carcinoma. It is rare and it's written it arises from collecting duct. So it's rare, it arises from collecting duct. There are 3-4 questions which are asked in pathology. What are those questions? First, it is having Hobnail pattern and it is associated with desmoplastic reaction. So it is having Hobnail pattern and it's associated with desmoplastic reaction. So this is Bellini duct carcinoma. There is one rare variant but asked in exam known as medullary variant. This medullary variant of RCC is exclusively seen. It is exclusively seen in children having sickle cell trait. Be careful, not sickle cell anemia, sickle cell trait. So 3 questions which are frequently asked. First, what is the most common type of RCC? Clear cell variant. Which one is having best prognosis, chromophobe, most common type seen in patients of cystic disease requiring hemodialysis, papillary. And the question which is also asked is exclusively seen in children suffering from or having sickle cell trait, and that is medullary. Now we are going to discuss the surgical aspect of RCC. So what are the various names of RCC? Have a look. RCC is also known as hypernephroma. It is also known as Gravitt's tumor, also known as radiologist tumor, also known as internist tumor. So these are various names of RCC. Now see why these names. Simple question. This is kidney. Usually RCC arises from which pole? It arises from upper pole. So since RCC arises from upper pole, when it was discovered, both surgeons and pathologists were thinking that origin is adrenal, not the renal. So since it arises from upper pole, that's why it's known as hypernephroma. Second question, Gravitz was a pathologist and he concluded that origin is renal. Origin is renal, not the adrenal. That's why it's known as Gravitt's tumor. Why radiologist tumor? Because there is prolonged period of stable disease. Means patient is asymptomatic and it is detected incidentally on radiological investigation. So incidentally diagnosed on radiological investigations. So it is incidentally diagnosed on radiological investigation. That's why radiologist tumor. And why internist tumor? Because of association with paraneoplastic manifestations. So it is associated with paraneoplastic manifestations. That's why it's known as internist tumor. So these are the various names. You must be knowing that RCC is the most common malignancy of kidney. It is more common in males, usually seen in 6th to 7th decade. Usually it is sporadic. What is the meaning of sporadic? Sporadic means it is scattered in the population. It is also associated with some hereditary syndrome like hereditary VHL syndrome, hereditary clear cell carcinoma syndrome, and hereditary papillary carcinoma syndrome. These are the hereditary syndromes with which RCC is associated. Now, what are the risk factors for RCC? Risk factors: smoking, tobacco, analgesic nephropathy, cadmium and asbestos exposure. Cadmium and asbestos exposure. Clear? So these are the risk factors for RCC. RCC are having some unique features which are usually not seen in other malignancies. What are those notable features or unique features of RCC? Have a look. Unique features of RCC. First, it's having a pseudo capsule. See, despite of having a malignancy, it's having a pseudo capsule. It is refractory to cytotoxic agents. It means it will not respond to chemotherapy agents. Third, but it shows response it shows response to biological response modifiers. And what are those biological response modifiers to whom it shows response? You have to remember this is IL-2 plus interferon alpha. Fourth, there is prolonged period of stable disease. Means patient is having RCC and patient is not having any symptom. And fifth, which is unique feature, what? Spontaneous regression is seen. Can you believe a lethal malignancy which can regress spontaneously? This is not the only malignancy which shows spontaneous regression. There are 5 malignancies which are having property of spontaneous regression. So this spontaneous regression is seen in 5 malignancies: mnemonic is NCR, MR. What are those 5 malignancies in which spontaneous regression is seen? N. Neuroblastoma. C. Choriocarcinoma. R. RCC. M. Malignant melanoma. And R. Retinoblastoma. So these are the 5 malignancies in which spontaneous regression is seen. This is very, very important. Now see what is the presentation of RCC. Clinical features. RCC is characterized by a triad. And what's the triad? Be careful. There is mass, there is pain, and there is hematuria. So there is mass, pain, hematuria. But be careful, this triad is not seen in all the cases. It is only seen in 10% patients who are having advanced disease. 10% patients who are having advanced disease. That's why what is the name of this triad? This triad is known as too late triad. Why? Because if patient comes with this triad, we tell the patient that it's too late. So that's why it's too late triad. Out of these 3 common sense question, which one is the most common presentation? And the most common presentation is what? Hematuria. So hematuria is the most common presentation. In advanced cases of RCC, sometimes patient is having non-reducing varicocele. So why there is non-reducing varicocele? Very simple, can you see? This is kidney, this is renal vein, this is IVC, this is renal vein, this is kidney. What happens? Here, the left gonadal one drains. Suppose there is a tumor thrombus inside. If there is tumor thrombus inside, what will happen? Because of this tumor thrombus, there is non-reducing varicocele. So usually there is non-reducing varicocele in advanced cases of carcinoma, renal cell carcinoma. Simple question. What kind of spread is seen in cases of RCC? Let me tell you. In most of the genitourinary malignancy, the route of spread is hematogenous. And most common site of metastasis is lungs. Example, RCC, hematogenous spread. Carcinoma bladder, hematogenous spread. Carcinoma prostate, hematogenous spread. Carcinoma penis, hematogenous spread. Testicular tumor, hematogenous spread. In majority of cases, most common site of metastasis is lungs. Exception, in CA bladder, malignancy goes to liver. Liver is the most common site of metastasis. And carcinoma prostate, most common site of metastasis is lumbar vertebra. And most common site of soft tissue metastasis is lungs. So basic question, have a look. Here, this RCC is having special property of vascular invasion. So can you see? This is RCC, kidney, this is renal vein, and this is IVC. What is this? This is right atrium and this is heart. Now see, the tumor thrombus invades renal vein. After that, it is going to invade IVC and it can reach up to right atrium. So most common route of spread is hematogenous. And what is the most common site of metastasis? It is lungs. In lungs, what kind of secondaries are seen? Can you see? Suppose this is lung and chest X-ray is performed. In this kind of secondary is seen. Can you see? What are these secondaries? These are known as cannon ball secondaries. So there is cannon ball secondaries. Cannonball secondaries to the lungs are also seen in testicular tumor. Which variant? Choriocarcinoma. So it is seen in RCC as well as choriocarcinoma, the variant of testicular tumor. After that, questions are asked. What is the most common malignancy responsible for bony metastasis in males? The most common malignancy responsible for bony metastasis in males is carcinoma prostate. And in carcinoma prostate, what kind of secondaries are seen? It is osteoblastic. So question, most common malignancy responsible for osteolytic secondaries in males is RCC. So RCC is the most common malignancy responsible for osteolytic secondaries in males. Second question, what kind of secondaries? Also osteolytic. And be careful, these are hypervascular. These secondaries are hypervascular. And that's why question is asked. What are the malignancies which are responsible for pulsatile secondaries? And be careful, these pulsatile secondaries are seen in RCC and follicular carcinoma thyroid. So pulsatile secondaries are seen in RCC and follicular carcinoma thyroid. After that, lots and lots of questions are asked about paraneoplastic manifestations. Now I'm giving you a simple tip. What is that simple tips? How to crack questions? Suppose you just remember a table and you don't remember that what is the most common. If you don't remember what is the most common, just mark the option which is placed at the top. Usually you are correct in 80% cases, not in 100% cases, but 80% cases. So any table which is given in the book, and if you are going to remember the option which is placed at the top, yes, usually it's most common or there is maximum percentage of that option. So see here, what are the paraneoplastic manifestations in RCC? Paraneoplastic manifestations. First, raised ESR. Second, anemia. Third, polycythemia. Fourth, hypertension. Fifth, hypercalcemia. And sixth, Stauffer syndrome. These are the types. Clear? Now, which of the following is most common? Raised ESR is most common. It is seen in more than 55% cases. So, most common paraneoplastic manifestation of RCC is raised ESR. What is the cause of anemia? When a non-functional mass replaces the functional part of kidney. Because of this, there is decreased erythropoietin production, and because of that, there is anemia. If a functional mass is there which produces erythropoietin, because of erythropoietin production, there is polycythemia. What is the cause of hypertension? If the mass is producing renin or compressing the vessel, there is activation of renin angiotensin system. What is the cause of hypercalcemia? It is because of PTH-RP. This question is frequently asked. It is caused by release of parathyroid hormone related polypeptide. Clear? Question is asked, out of these paraneoplastic manifestation, there is only one which is completely managed medically. And what's that? Hypercalcemia. How we are going to manage it? With the help of bisphosphonates. These are medically managed with the help of bisphosphonates. What are those bisphosphonates? Alendronate, pamidronate, zolendronate, and you must be knowing that these bisphosphonates should be taken with plenty amount of water. Patient should be in standing position minimum for half an hour to prevent esophagitis. What is the cause of Stauffer syndrome? Stauffer syndrome is non-metastatic hepatic dysfunction. Non-metastatic hepatic dysfunction. Now see what is the meaning. A patient of RCC is being admitted to your ward. After 10-15 days, patient developed jaundice. Bilirubin is raised, ALP is raised, ultrasound CT was performed. There was no metastasis to the liver. So what is the cause? It is mainly because of interleukin 6, and this is non-metastatic hepatic dysfunction. Generally, it improves after tumor resection. So these are paraneoplastic manifestations which are frequently asked in exam. After that, what are the investigations which are performed? I told you one basic principle. For most of the renal tumors except Wilms tumor, what is the investigation of choice? CCT. So investigation of choice for diagnosis is CCT. Second very important question. What is the investigation of choice for detecting tumor thrombus? Detecting tumor thrombus. Doesn't matter, this tumor thrombus is in IVC or renal vein, and the investigation of choice is MRI. It will differentiate from bland thrombus, differentiate tumor thrombus from bland thrombus. And if I want to assess IVC involvement or IVC invasion, the investigation of choice is inferior vena cava gram. Inferior vena cava gram. It's the gold standard. It's the gold standard investigation for IVC invasion. So the gold standard investigation for IVC invasion is inferior vena cava gram. Be careful, all these three questions are frequently asked in exam.